Hi everyone! Welcome to the 7th module of the 6th edition NTP-MOP training. We are now down to our last 3 weeks of our training, and I'm so glad that you are still with us in this journey. At this point, you were able to learn a total of 6 modules and accomplish 9 exercises. So for our module 7, we are going to discuss about initiation of TB treatment among DS and DRTB patients in special situations. For our learning objective, at the end of this session, participants will be able to administer appropriate treatment regimen to DSTB and DRTB patients with unconventional situations. Here are the special situations that we are going to learn on how to go about the management and treatment. We have children, pregnancy, breastfeeding, contraception, diabetes mellitus, liver disorder, renal failure, seizure disorder, psychiatric disorder, HIV, and substance dependence. To begin, let's talk about management of TB in children. As a review, the pediatric age group is defined as children 14 years old and below. Now, you have learned about DSTB treatment as discussed in the module about that. So the regimen for children with DRTB should consist of 4 to 5 drugs and given in the entire course of treatment. A proposed regimen with corresponding dosages should be presented to the TB Medical Advisory Committee prior to initiation of treatment. It should be done immediately so as not to delay treatment initiation. We have to avoid injectable agents, which will affect the child's language development and social skills. It is important to determine the severity because it will be the basis for the treatment duration. So this table shows the standard all-oral regimen for children. So we have regimen 6, standard all-oral regimen for fluoroquinolone susceptible, and regimen 7, standard all-oral regimen for fluoroquinolone resistant. So regimen 6 and regimen 7 are further classified as regimen 6A for 3 years old below. We have 6B for 3 to 6 years old, and then regimen 6C for 6 years old and above. And you also have regimen 7A, 7B, and 7C as reflected in the table. So this is the composition of the regimens. The duration of treatment is based on the severity of the disease as shown in the next slide. The severity of TB disease in children is determined based on the presence of any one of the criteria. First, positive TB bacteriologically. We have through smear microscopy, expert, or TB culture. Cavities or bilateral disease on chest radiography. Extrapulmonary forms of disease other than lymphadenopathy or peripheral nodes or isolated mediastinal mass without compression. And presence of comorbid condition or disease such as severe malnutrition or advanced immunosuppression. Now, if the disease do not have any of the above mentioned parameter, the disease in non-severe and the duration of treatment is 9 to 12 months, depending on the clinical progress as assessed by the physician. Now, if any of the parameter is present, the disease is severe or extensive. Hence, the duration of our treatment should be 15 to 18 months. To monitor the treatment in pediatric age group, we have to consider the bacteriological status at baseline. Now, if children with no bacteriologic confirmation at baseline, we have to monitor clinically. So this includes resolution of TB signs and symptoms, monthly weight gain and growth through weight and height chart for children less than 5 years of age, baseline CXR and follow-up CXR of month 6 to check resolution of lesions in case of PTB. And also we have to check for healing of other EPTB lesions, example called abscess. Now for children who have bacteriologic confirmation at baseline, we have to monitor clinically as mentioned above, and then we have to do follow-up bacteriological monitoring schedule for sputum and culture test, like that of the adults. That was for our TB patients who are children. Now moving forward, we have pregnancy. It is important to ascertain whether or not a woman is pregnant before she starts TB treatment. Hence, we have to determine OB history, especially the last menstrual period, and we have to include pregnancy test as part of baseline. Now, we have to emphasize that our patient should avoid pregnancy during her treatment. We have to encourage family planning and offer effective and appropriate method of contraception. We have to reassure that most of our first-line drugs are safe for pregnant women. In case our patient becomes pregnant, advise her that a successful treatment of TB with our standardized treatment regimen, that is 2 months of HRZE and 4 months of HR, is important for a successful outcome of pregnancy. We have to give pyridoxine or vitamin B6 at 25 milligram per day for our patients who take isoniazid. Now, if our patient becomes pregnant during the treatment, we have to follow up the newborn for 12 months postnatal to check for congenital anomalies. For MDR-TB, it is important to determine the severity of TB disease relative to the initiation of treatment and for proper management. Now, this is what are we going to do if our patient is clinically stable with minimal radiological disease. Treatment may be deferred until the second trimester with close clinical follow-up. Now, if our patient is clinically unstable, MDR-TB treatment that is effective and safe for the mother and baby should be initiated immediately. We have to avoid, however, potential teratogenic effects, and that is brought about by our second-line injectables and prothionamide. Now, we have anti-TB drugs specifically for DRTB. We have delamanid that is potentially teratogenic in animal studies and therefore should be avoided until more data is available. And then our BDQ or our bedaquiline demonstrated to be safe in animal studies. Hence, it may be considered for pregnant patients, but we have to weigh the risk and benefits. Now, if we are not going to treat our pregnant TB patients, they have higher rates for complications of pregnancy. So, would include preeclampsia, vaginal hemorrhage, and fetal loss. Now, what is the DRTB regimen for pregnant patient? This would include 3 to 4 oral medicines deemed to be effective, but again, emphasizing we have to exclude injectable agent because they are particularly toxic to the developing fetal ear, or what we call it is ototoxic, specifically during the first trimester. And also we have to avoid prothionamide because of an increased risk of nausea and vomiting and teratogenic effects as well. So this table shows the classification based on our FDA classification of our anti-TB drugs. And so we have safety class A, B, C, and D, and then their corresponding interpretation, and then which of our anti-TB drug belongs to these classes. So for safety class A, they are considered the safest uh, drug of all. So we do not have anti-TB drugs that is established to be really safe based on human studies. However, we have for safety class B, they are considered presumed. They are considered safety or presumed safe based on animal studies. However, no human studies conducted yet. So under this class, we have ethambutol, meropenem, amoxicillin, or clavulanate, and bedaquiline. Okay, they are the safest. And we have safety class C. This means that these drugs are uh, uncertain if they are safe. So no human studies conducted yet, but animal studies show adverse effect. So we have isoniazid, rifampicin, pyrazinamide, our fluoroquinolones, capreomycin, our ethambutol, or ethionamide rather, proteonamide, cycloserine, para-aminosalicylic acid, our clofazimine, uh, our levofloxacin, linezolid, moxifloxacin, and our imipenem rather, and cilastatin. So most of our anti-TB drugs belong to this safety class. And then lastly, these are considered unsafe drugs. So evidence of risk that may be justifiable under certain clinical circumstances. So we have amikacin and streptomycin. Now we have to remember that for our pregnant TB patients, we have to present cases to TB Medical Advisory Committee, or our TB MAC, because they will decide what the RTB regimen is fit for them. Delaying treatment carries a risk as TB can advance quickly in a pregnant patient. The decision is based primarily on clinical judgment established on the basis of signs and symptoms, severity and aggressiveness of the disease. Now, another special situation is for our breastfeeding mother. A breastfeeding mother afflicted with TB should receive a full course of TB treatment. It is relatively safe. Timely and properly applied treatment is the best way to prevent transmission of the tubercle bacilli to the baby. So, drugs in the breast milk will be found in concentrations equal to only a small fraction of the therapeutic dose used in infants. Effects of such exposure in infants have not been established. But we have to remember to educate our lactating mother to feed their baby first before taking medications. However, if our patient is sputum positive, we have to advise that she discontinues breastfeeding. So we have to limit contact of the child to the mother, especially if the mother is not adherent to treatment or still with positive culture. Now, special consideration, our BDQ and delamanid are excreted in breast milk based on animal studies. Again, our delamanid is considered teratogenic. So you have to decide whether to discontinue the drug or breastfeeding should be an alternative solution. We have either to discontinue the drug or discontinue the breastfeeding. Again, we have to limit contact of the baby to the mother, and if contact should occur, it should be in an open air space if possible. And the mother should wear surgical mask or N95 respirator. We have to give supplemental pyridoxine to the infant whose breastfeeding mother is taking isoniazid. Now we move on to contraception. There are also a number of reminders that we have to consider in managing for our patients who are taking oral contraception. So basically, we have no contraindications to use of OCP with non-rifamycin containing regimen. So birth control is strongly recommended for all non-pregnant sexually active women receiving therapy for drug-resistant TB. Okay. Advise a woman receiving oral contraceptives while on rifampicin treatment that she has the following options. She can either use an oral contraceptive pill containing higher dose of estrogen, or she can use another form of contraception. So we advise this because OCP increases the risk of decreased protective efficacy against pregnancy. So our patient might get pregnant if she takes anti-TB drugs at the same time and then she's taking OCP. So we increase the dose or we change another method. Patients who vomit directly after taking an oral contraceptive can be at risk of decreased absorption and therefore of decreased efficacy and should be advised to use a barrier method of contraception. So that's it for our patients who are taking or on contraception, taking OCP. Moving on, now how are we going to manage our diabetic patients? It is known that diabetes mellitus multiply the adverse effects of anti-TB medicines, especially renal dysfunction and peripheral neuropathy. Now, insulin is the preferred medication to control blood glucose level. This is to achieve optimal blood glucose control with strict glycemic control. Cautions to consider when managing patients with diabetes: the use of nephrotoxic agents such as aminoglycosides, specifically, for example, arkanamycin and amikacin, and the use of neurotoxic agents such as linezolid. Another important point: co-administration of bedaquiline and hypoglycemic agents such as sulfonylureas and linides, since these agents function by inhibiting ATP-dependent potassium channels, thus delaying repolarization. So this could lead to QT prolongation. Another important reminder: co-administration of BDQ and potentially hepatotoxic hypoglycemic agents such as thiazolidinediones. Now let's move forward. To liver disorder. Baseline examinations may show elevated liver enzymes such as ALT and AST. So this may be due to disseminated TB. Among the first-line drugs, isoniazid, rifampicin, and pyrazinamide are associated with hepatitis. Rifampicin is the least likely to cause hepatocellular damage but is associated with cholestatic jaundice. Pyrazinamide is the most hepatotoxic agent among our anti-TB meds. Now, what are we going to do? We have to hold our treatment if ALT elevation is more than 3 times the upper limit of normal and there is hepatitis and or jaundice. And also we have to hold if ALT is elevated 5 times the upper limit of normal and in the absence of symptoms. We have to wait for liver function tests to revert to normal and clinical symptoms to resolve before introducing the anti-TB drugs. If liver function tests cannot be done, it is advisable to wait an extra 2 weeks after resolution of jaundice and upper abdominal tenderness before starting TB treatment. Okay. Once drug-induced hepatitis has resolved, the drugs are reintroduced one at a time. Okay, so we have to do drug challenge or re-challenge. So we have to start with the least likely drug to cause adverse reaction, and then the dose is gradually increased over 3 days. Now, if there is no reaction after the third day, add the second drug at a small challenge dose. The procedure is repeated, adding in one drug at a time and gradually increasing the dose. Now, if a reaction after adding in particular drug happens, so that identifies the drug that is responsible for the reaction. So you have to stop permanently any drug identified to be the cause of a severe reaction, and this may be replaced by another anti-TB drug. Our patients with chronic liver disease should not receive pyrazinamide. So alternative regimens are 2 months of streptomycin, isoniazid, rifampicin, and ethambutol, and then 6 months of isoniazid and rifampicin. Or we have 9 months of rifampicin and ethambutol, or we have the regimen 2 months, streptomycin, isoniazid, and ethambutol, and then for continuation phase, we have 10 months of isoniazid and ethambutol. Now, for acute viral hepatitis, you have to defer treatment until the acute hepatitis has been resolved. When it is necessary to treat TB, the safest option is we have 3 months of streptomycin and ethambutol. And once hepatitis has resolved, we have to follow with continuation phase of 6 months of HR. So that is 3 SE and then 6 HR. Now, if the hepatitis has not been resolved, SE should be continued for a total of 12 months. BDQ and delamanid are not contraindicated in case of mild to moderate hepatitis. However, in severe hepatitis, we may use them, but with caution. That was for liver disorder. Now we move on to the management of our TB patients with renal failure. Renal failure may be due to any of the following: concomitant renal problem, result of previous drug-resistant TB treatment with second-line injectables, and disseminated TB with renal involvement. This table shows the recommended dose and frequency for patients who have creatinine clearance of less than 30 ml per minute and those having renal dialysis. So unless otherwise indicated, dose after dialysis. Now for isoniazid and rifampicin, there is no adjustment necessary. For ethambutol, we have 15 to 25 milligram per kilogram per dose to be given 3 times per week, so not daily dose. And then for pyrazinamide, 25 to 35 milligram per kilogram per dose, also 3 times per week. For rifabutin, normal dose can be used if possible. We have to monitor drug concentration level to avoid toxicity. With the use of rifampicin, we have no adjustment necessary. Levofloxacin, 750 to 1,000 milligram per day, 3 times per week. With moxifloxacin, ethionamide, and prothionamide, no adjustment necessary. For cycloserine, we will be adjusting the dose to 250 milligram once daily or 500 milligram per day to be given 3 times per week. And for PAS or para-aminosalicylic acid, we have 4 grams per dose. That's twice daily maximum dose. For BDQ, no adjustment necessary. In mild to moderate renal impairment, so no established dosage in severe renal impairment, but we have to use with caution. For the delamanid, no adjustment necessary in mild to moderate renal impairment, no established dosage in severe renal impairment, and also we have to use with caution. For clopazimine and linezolid, no adjustment necessary. However, for our AMOX and CLV, creatinine clearance of 10 to 30 ml per minute, we give 1,000 milligram twice daily for amoxicillin component. And then for creatinine clearance of less than 10 ml per minute, 1,000 milligram once daily for amoxicillin component. For high-dose isoniazid, recommended dosage not available. For streptomycin and amikacin, we have the same adjustment, 12 to 15 milligram per kilogram per dose, 2 to 3 times per week. For imipenem and cilastatin, creatinine clearance of less than 20 to 40 ml per minute, we give 500 milligram every 8 hours daily. For clearance, creatinine clearance of less than 20 ml per minute, we give 500 milligram, but every 12 hours daily. For meropenem, creatinine clearance of less than 20 to 40 ml per minute, we give 750 milligram every 12 hours, daily dose. So creatinine clearance of less than 20 ml per minute, we give 500 milligram every 12 hours, daily as well. Now we have this guide in computing creatinine clearance, or we can use iOS and Android and check for, or we have to download QX Calculate to make our life easier. So the needed data would be age, sex, weight, and the creatinine levels. To continue for regimen 1, with the adjustments stated in the table, we may give the following. For drug FDC, that's HRZE, 3 times a week. We can give Monday, Wednesday, and Friday. And then we give a 2-drug fixed dose combination, or HR, for the rest of the week. So that's Tuesday, Thursday, Saturday, and Sunday. And then for continuation phase, we give 4 isoniazid and 4 months of HR, isoniazid and rifampicin. So we have another safe option here. We give 2 months HRZ and then 4 months of HR. So we have to give anti-TB medications after hemodialysis. BDQ and delamanid are not contraindicated for mild to moderate renal insufficiency, but with severe renal insufficiency, these drugs may be used, but with caution. Dosing of drugs should be adjusted per patient's creatinine clearance or estimated glomerular filtration rate. Okay, so that was for our patients with liver disorder. Now, moving on with our TB-HIV co-infection. So what are we going to do with our patients? So there is increased mortality in patients with TB-HIV if patient is not treated with antiretroviral therapy. So proper coordination should be done between the treatment hub and healthcare provider and TB facility to discuss potential drug-to-drug interactions. So in patients with HIV-related TB, the priority is to treat TB, especially if our patient is bacteriologically confirmed, so to stop transmission. However, it can also be simultaneously done, but we have to manage carefully. Patient with HIV-related TB can have antiretroviral therapy and anti-TB treatment at the same time. So we just have to carefully evaluate in judging when to start our ART. That's why we have to closely coordinate with our treatment hub for the entire duration of the management of our TB patient with HIV. ART should be started within 8 weeks from MDR or RRTB and the STB treatment. Patients with CD4 of less than 50 cells per millimeter cube, we have to start within 2 weeks. So patients with TB-HIV co-infection should also receive cotrimoxazole as prophylaxis for other infections. So persons with HIV infection who, after careful evaluation, do not have active TB should be treated for presumed latent TB infection. So that is through our TPT, which was discussed previously by Sir Lito. And I also discussed in the TB screening on how to screen our HIV patients for TB. So I hope you still remember that. Now, for co-administration of BDQ and antiretroviral drugs, replace EFB with nevirapine if the virus is still susceptible and patient has no toxicity to NVP, because efavirenz decreases BDQ blood concentration level by 52%. So allow 5 days washout if EFB is to be replaced with NVP. So, however, if patient is critically ill, start MDR-TB treatment immediately. No need to wait for washout period. You have to take caution of the potential risk of additive adverse event with the use of linezolid in patient with HIV. So that would be neuropathy and myelosuppression. With dolutegravir, which is now becoming widely used, there's no significant interactions with BDQ, delamanid, or linezolid. Now for our psychiatric patients, how are we going to manage them? So basically, the chronicity of the disease is already depressing in itself, right? So our patients is at risk for anxiety and depression. And aside from the disease, because of socioeconomic stressors as well. So special caution should be considered in using particularly our cycloserine, but this is not absolutely contraindicated. Now, patients with psychiatric disorder should undergo psychiatric evaluation prior to start of treatment. Now, we have to emphasize that family support is important, and they should be educated about cycloserine toxicity and instruct them to contact healthcare provider for any changes in patient's behavior. Individual or group therapy session and treatment with psychiatric medication may be necessary to manage patients with psychiatric condition or neurotoxicity brought about by drug-resistant TB treatment. Always give pyridoxine if regimen contains cycloserine. So that is 50 milligrams for every 250 milligram of cycloserine. Now for our patients having seizure, so our cycloserine and high-dose isoniazid can cause seizures. Avoid cycloserine and high-dose isoniazid in patients with active seizure disorders that are not well controlled with medication. So in cases where cycloserine or high-dose isoniazid is a crucial component of the treatment regimen, it can be given and the seizure medication adjusted as needed. So this would be our dosage for pyridoxine. 10 to 25 milligram per day for at-risk patients on isoniazid, and then we give 25 to 50 milligram for every 250 milligram of cycloserine, and then 10 to 50 milligram per day for pediatric patients at risk for neurological sequela. Now for our patients who are substance dependent. So patients with substance dependence disorder should be referred for therapy in specialized institutions. So special caution should be considered in patients taking cycloserine. Now, it is important to assess our patients for alcohol use, and we have this helpful tool, our CAGE questionnaire. So CAGE is derived from the question of the tool, C for cut down, A for annoyed, G for guilty, and E for eye opener. So we have to ask our patients these 4 questions and use the scoring method described below here to determine if substance abuse exists that needs to be addressed. So we have question number 1. Have you ever felt you should cut down on your drinking? For question number 2, have people annoyed you by criticizing your drinking? For question number 3, have you ever felt bad or guilty about your drinking? And for question number 4, have you ever had a drink first thing in the morning to steady your nerves or to get rid of a hangover? Or do you need an eye opener? Now, item responses and the CAGE questions are scored 0 for no and 1 for yes answers, with a higher score being an indication of alcohol problems. A total score of 2 or greater is considered clinically significant. I think that's the end of our presentation. So thank you very much for your kind attention, and we can now move on to our exercises. See you on our next modules. Keep safe and keep healthy.